Hello everyone, and welcome to our webinar on the mental health care and classification system with Mental Health Australia and IHPA joint forces to present you some information today. I'm joined in the conference room here by James Downey from IHPA and Jennifer Nobbs, and we're going to skip pretty well straight into the presentation. Obviously, this issue of classification is a really important one for Mental Health Australia, and our partnership with IHPA on some of these issues has been very important to us as well. From the origins, which I'll let James explain, we recognise that for the mental health system, the mental health classification system and activity-based funding was not necessarily an easy fit. We start a bit behind the 8 ball relative to where hospitals are starting this process, and so we've had a fair work to do to catch up, and I think we've still got a fair bit of work to do to really capture the issues for the sector. But I also think it's true to say that they're for a range of reasons that we'll explore over the course of this seminar, a very important issue for the mental health sector to have its head around, and very important discussion for us to be part of. So without further ado, I think over to James, who's going to start to take us through the presentation, and hopefully we'll get through that in time to leave plenty of questions at the end. So thanks, James.
Thanks, Frank. I guess the obvious question is, why are we doing all this? And if you go back to the National Health Reform Agreement, the very first point in the National Health Reform Agreement is about improving the health outcomes for Australians, and I guess in today's context, more specifically the mental health outcomes for Australians. And how are we doing that? So it's about ensuring that we've got more sustainable services and transparent decision making. And of course, to do that, what we really need is a system that helps us to better describe how mental health care is provided and what the costs are. And to do all this, we really need a good classification system to explain what the services are that patients receive and what the costs of those are. So what are the benefits to the mental health care community of having a good classification system? The first is increased transparency and improved cost prediction. So having a way that we can predict what the likely costs are of patients and clients. We get accurate and consistent data about the services provided across different mental health care settings. So we really are trying to expand this beyond just hospitals and just inpatient wards. We've been very clear about that from the outset. It'll give us a better understanding of mental health consumers and the services they're receiving. We'll support new models of care by giving integration across settings. It gives great potential for improved resource planning and distribution. So by having a good understanding of what's being delivered where and what the costs of that are. And it gives us an ability to do benchmarking about performance and cost, and hopefully eventually further down the track about outcomes as well. So there's a whole lot of potential in having a good classification system. So IHPA is a creature of the National Health Reform Agreement that was signed by all First Ministers in August 2011. But activity-based funding has been a requirement of Commonwealth funding for a lot longer, so it's been around for 22 years now in Victoria and South Australia, but nationally has really been a big thing since 2008. The 2011 agreement is what established IHPA, so we're an independent authority. We are governed by a board, which is the authority itself, of 9 members. And it's chaired by Shane Solomon, who I'm sure many of you know from his work in Victoria and more recently with Telstra Health. Our work is more than just ABF, so it's all of the infrastructure that is required for an ABF system, so classification systems, costing systems, data standards, and of course the pricing model. So how is our work used? So when our work around activity-based funding is used, its primary purpose in terms of the National Health Reform Agreement is to determine how much funding the Commonwealth contributes to each local hospital network around the country. And so that's a direct output of both our price and the activity that each LHN do. So that sets the Commonwealth funding, and then states and territories can pay above or below the national efficient price. So we know that in Victoria, they are significantly under the national efficient price. In some other states, the price paid by the states is above the NEP. And importantly, it's important to understand that states and territories are the system managers, and their role is to set the volume of services and the distribution of services. That's not IHPA's role. We don't say there should be a heart transplant service here or this particular mental health service there. That's absolutely the role of states and territories. So how do we do it all? We have classification systems. So as I said, these are about explaining different types of different groups of patients who have similar diagnoses and procedures in most of our classification systems. But as we'll explore a little later, mental health's a little different. But we group patients into groups that are clinically relevant, they have similar conditions and have similar costs of service delivery. We undertake costing, so we have cost data from over 300 hospitals around the country, and that cost data covers the full spectrum of hospital services. So the classic inpatient services that we've been collecting for many years, but more recently expanding that into emergency department presentations, outpatients, community services that are delivered by hospitals, and mental health and rehab. And then, of course, we need to count all of that activity. So we have activity files from each state and territory that have, at a patient level, each patient interaction around the country. And then finally, we take all of this data into our national pricing model, and this is how we determine the national efficient price. So at the moment, we determine the national efficient price on the basis of the average cost around the country, and that's the price that's paid by the Commonwealth. And then for each individual classification group, we have a price weight, and the price weight multiplied by the price is the price paid for that service. So I'll hand over to Jennifer now, who's going to give us a bit more of a detailed run through the mental health work.
Thank you. So the current arrangements in public health services don't directly relate to ABF in a sort of normal business as usual way at the moment. So what I'm going to do is run through the changes that we are looking to make and the process that we've taken to investigate those. And then when it comes to the end of that, be able to explain a little bit about how it will affect the broader mental health sector, how it will do that in terms of your relationships with state services, and how it may do that if you want to expand the utility of the mental health classification. So at the moment in the public sector, admitted mental health services, those that happen in a hospital, we use an existing classification system for them called ARDRGs. Those are based on diagnosis, and we price mental health services based on diagnosis. That's not ideal in the longer term, but we've adjusted our pricing model at the moment to make it as fair as possible. Non-admitted mental health services, so those that happen broadly and either in day clinics or in the community that are run by the public system, are currently block funded. So at present, we made the decision that we don't know enough about those services to provide, we don't have enough fine detail to fund them more accurately. Mental health in the emergency department is dealt with very separately, and we deal with emergency department services in a quite different way and will continue to do so. What we've known is at the moment the current system doesn't really reflect the care that is provided to individuals at the moment. It's based on diagnosis, and we all know that diagnosis is not the best indicator of somebody's situation, the care that needs to be provided to them in the mental health space. It also doesn't support new models of care. It provides a label for somebody and doesn't allow flexible treatment from the community to admission to hospital when needed and back again. The separation between the admitted and non-admitted space isn't reflective of the practices that jurisdictions and non-gov services are leading the way in, and we wanted to develop something, if we are to price mental health services differently, that reflected those new models of care and looked at the individual more broadly, looked at the consumer and said it's not just about your diagnosis. Two different people with schizophrenia have very different lives, very different care needs, and are genuinely different people. So we wanted to look at something that did things a little differently. So from that, we decided to develop a new mental health care classification. And the purpose of this is to improve the cost predictiveness, to look at those factors which influence the type of care and the cost of care beyond simply diagnosis, and see what we could understand about an individual and about the care they receive that could better predict the costs associated with it. That would support new models of care, so allows flexibility to move between community and admitted care and to other services as well. And covers all those services where specialist mental health care is provided. That leads on to the dot point that you can see below that, which talks about mental health services first and ABF second. So we come from an environment where we look at ABF generally in the first instance, but we have an opportunity here to develop a way of classifying and understanding mental health care that goes much more broadly than that. So in developing the classification, there are several parts to the process of ending up with a product that we can price, and we wanted to make sure the first parts of that are as broad as possible so that they've got use beyond the ABF funding environment and can be picked up by all of those working in specialised mental health care for use to understand their services and their consumers better. So very briefly, we've been collecting data about this over the last year or nearly 2 years now, and are just about to run a pilot that will test a first version of the classification. So what I'm going to do is take you through the steps that have been steps that we've taken to develop that, and then we can take some questions at the end. So guiding that work, we've got a large working group which consists of a number of different stakeholders, including Mental Health Australia and Community Mental Health Australia, plus the states and territories in the Commonwealth, clinical experts, the National Mental Health Commission, consumer and carer reps, and psychiatrists and psychologists there as well, and the NDIA, because we think that there's that it's important that we look at the two very big changes that are happening in the way that health and disability services will be provided in the future. So our working group meets regularly and has been guiding this work. And the project that they've been overseeing has 6 clear steps to it. The first is to define the services to be included. The second is to identify the cost drivers. So what's in scope in the first place, and then what are the things that are driving the cost of providing care. Then the third step was to undertake a costing study, and I'll come back to all of these and consider them in detail. Then on the basis of that, develop a classification, test it, and then begin a long and ongoing process of more data collection and review to refine the classification over a number of years. So the first step was to define the services, and the definition that you can see on your screen was developed by our mental health working group with input from a large number of people. The University of Queensland first did a report where they engaged with a number of stakeholders to develop something that said this is the type of care that's provided to somebody where the main goal of care is mental health care, and it includes individualised mental health assessment and care plan. So there has to be a care plan of some sort for that person. It's managed by or regularly informed by a clinician with specialised expertise in mental health. They don't need to be present all of the time, but there needs to be some formal understanding of the care that's to be provided. And importantly, it may include significant psychosocial components, including family and carer support. So it's by no means limited to clinical support provided in a hospital or out of hospital setting. The second part of the process was to look at the cost drivers so those factors in an individual's care that might influence the cost. And to do that, we engaged the University of Queensland to do a large report that looked at data and international learnings to say, beyond those things that we know and data that we collect about an individual, what other things might be important beyond diagnosis, beyond age, beyond the number of individual factors? What do we need to look at that provides a bit more information? So the first factor they suggested was the phase of care, and this is a new concept. It's about saying, what's the prospective goal of care? So when you are looking at a consumer and their ongoing care, what where do you think they're headed? Are they in an acute phase of care where they might be in a hospital, or is some very intensive support in the community when you're really trying to manage some acute symptoms? Or are they in an ongoing phase of recovery, whether that be intensive or the care needs to be delivered less regularly? What's the intensity of that care that's being provided? The second area that we looked at was how recently have they had a relationship with the service that's providing that care. So what do we know about them already? The third was what sort of interventions, what treatment, what care is being provided to them, and we used a tool called the MIC, the Mental Health Intervention Classification, to test this, to say, are there certain sorts of individual or group therapy, assessment, medication, are there certain particular sorts of interventions that drive the cost of care? And finally, and very importantly, what are the outcome measures? How are we, by collecting some information about their social functioning and level of ability to function in the community, medication, relationships with people, how likely is this to influence the cost of providing care to them? So there's a large report that's available on IHPA's website which goes into that in detail, and you can see the link at the bottom of this page that talks about how we consider those. But once we'd taken those new ideas, we undertook a costing study last year. It ran from July to December in a number of different services across Australia. For this cost study, we focused on public mental health services. The reason being that there are already a number of different data items, information about consumers that are mandated through collections required of public services. And so we were able to collect a significant amount of data that could inform future work. The NGO sector wasn't particularly targeted in this study at that time because the ability to collect consistent data across those services wasn't there as yet. So our starting point was a clear data collection where we could add on a few data items. So existing data items and those that we looked at in the previous slide. So that ran from July to December last year, and there's more information about that on the Health Consult website. They are the consultants that ran that for us. So armed with that data, we've convened a group of people, and you might recognise the names up on that screen. Sebastian Rosenberg in particular is involved with Mental Health Australia to look at the data in detail and report back to that broader mental health working group that we saw earlier. So they've guided our work, and we're meeting with them again early next week to look at a draft of the classification. They're the ones that have pored over the data and asked us all the difficult questions back. So we've been meeting with them regularly. And the key findings from the work so far, and the table that you'll see on your screens shows the different concepts that we're looking at and the different levels of the classification. that we've been considering. So you can see that in the first instance we look at the setting. Ideally we would like to look at the setting later on in the piece, but in order to be able to identify consumers, a single patient identifier isn't there across our system across all states and territories yet. So we've started with looking at the setting within which an individual is treated. Then we've looked at the phase of mental health care, so that intended goal of care and a measure of intensity. Then we've started to look at age groups, and within that, the different outcome measures, so the HONOS, the life skills profile, the CGAS, which is limited to children, RUG-ADL, which is a specialist older persons measure, as is FIS. We've looked at some other factors as well, legal status, whether they were known to the service recently, diagnosis, because we think it's a significant factor even though it might not be the driving one, at least to distinguish between broader groups of care, and other patient episode characteristics that might be of use, as well as interventions. So we've been looking at all of those things, and our expert reference group have been working through them to develop a model that best explains care. So from that, this is a very, very early draft of the classification, and you'll be able to see a later draft later in the year when we release a consultation paper. But you can see that we're looking at you can see the factors that you saw in the previous slide in a way that you can see how it would the consumer flows through the system. So these are the sorts of things that we're considering at the moment in this early draft, and hopefully this diagram explains them a little bit better to you. So that's where we're up to in the classification at the moment, and you can see that we're at the stage where we've developed an early draft of it and we're beginning to test it. The way that we're beginning to test it is through a consultation paper, which you'll see later this year, and some specialist consultations with individual groups. For example, we intend to meet with child and adolescent psychiatrists and psychologists. We're engaging with Mental Health Australia through these sorts of mechanisms to engage with the broader NGO sector, and Frank might talk about that in a minute. And we're running a pilot in a number of other services to test the structure of the classification and see if it delivers the results that we expect. So you can see from here we'll be testing that classification, and then we'll be refining it on the basis of those consultations and tests to deliver something that can be released publicly for use. But that's certainly not the end of the road with this. We require an awful lot of data to continue to refine it. So once we run it through the public sector a bit more, we'll be able to use that. And you can see from this slide that our ongoing work involves constant refinement to classifications. So we continually refine them. We consult every year through classification consultations and through our formal mechanisms on our work plan and our pricing approach. In terms of the focus work at the moment, we're running a consultation paper, and as I mentioned, a pilot rather, and as I mentioned, a consultation paper. We'll also undertake some additional one-off studies to address particular areas that we think need further review early next year, and then we will deliver a first draft proper in the new year. So that's a very sort of quick overview of where things are up to. I might now hand over to Frank to explain how Mental Health Australia have been working with us to support the work.
Sure, thank you. I think I'll just reflect for a moment that we were very eager to be involved in this right from the outset, because I think there, as we've already heard, there are a range of reasons why mental health classification is going to be important, and I just want to briefly talk about a couple of those trends that we haven't touched on much. In a range of areas we're moving towards individualised funding. In a range of areas we're moving towards outcome-based funding. In a range of areas government is moving towards new commissioning models for mental health service programs. We're on the brink, we think, of hearing how the government's going to respond to the National Mental Health Commission's report. And there are a whole raft of reforms afoot, including the reforms to health, reforms to the Federation White Paper process, the implementation of the National Disability Insurance Scheme, the reforms that have primary health care, the rollout of primary health networks. All of these things tell us that it's important to be part of a system that allows us to count and monitor our activities much more closely than we have previously. When we first came to this area, we felt very much like foreigners in a strange land. The natural language of activity-based funding is around, hip replacements and surgical procedures and those things that we understand pretty well in a hospital setting, can be pretty easily described and counted. Mental health, we haven't traditionally described or counted our activities in the same way, and that's why we felt it was very important to working with IHPA on these very significant reforms. And I just want to talk briefly a little bit how we've done some of that. We think that the opportunity that activity-based funding provides is something that really the mental health sector more broadly needs to be quite actively engaged in. So since November 2014, we've been involved with IHPA in what we're really describing as a sort of capacity building exercise. But even before capacity building, a lot of the activities that we're involved in have been about knowledge and understanding, because, as I said, this is not a natural area for many in the community mental health sector to be involved in. So we've been involved in the preparation of fact sheets and websites and information papers and various submissions to IHPA's work. You will see through our weekly updates and through social media and other online activities that we've been really trying to convey information out to the sector and ensure that the information is well understood and the processes that are well understood. We've been pleased to work with our partners, Community Mental Health Australia, to reach out to organisations through various workshops that have been conducted in New South Wales and Victoria, and in the convening of a working group. All of those things are available online, and I think you're at all interested in pursuing some of those things or haven't been involved in some of those things to date, then you'd be very welcome to pursue that. It's also true in partnership with CMHA, we conducted a national survey across the jurisdictions to get to understand our state of readiness, and we are about to that work to IHPA, and I imagine that will start to inform our future work as well. We've been through many of the benefits and challenges in this area, and so I'm not going to dwell on those at great length, except to say that I guess as in any classification system, work has to begin somewhere, and I think we learn by doing in lots of ways. And so the first attempt that we've made at engaging on these issues are really just the start of a process, I think it's fair to say, and must be start of the process. The concern that we approach the area with is that if we run the risk that if we're not involved in the areas, that the focus of the mental health system will remain on hospitals and hospital-based activities, and work for us is principally around ensuring that we are able to reach out into the community sector, because, as you know, mental health policy for more than a decade now has really focused on moving care out of the hospital, in particular the acute system, but out of the hospital setting altogether and into the community, both because it has a low impact on the individuals involved. So developing a comprehensive classification system that can allow that to take place and allow the continued focus on community mental health, but also allow us to hold our own in a debate and a discussion about the resources that government will provide to various sorts of services. We'll be needing to ensure that we can identify and describe and count the activities in community mental health, as well as we describe those in other settings. I think there's, as I said, a lot of work yet to be done, and we're really beginning a process, and I'd encourage you to remain involved in that, because it's really only through your involvement in this work that we can ensure that community managed mental health remain focused, that we can ensure that the service and funding models and incentives and impacts don't go awry, so we don't want to create perverse incentives and encourage a system that might provide care in settings that we're unhappy about or that are less than optimal. I think we heard earlier that we want the service models and the systems and the care to drive activity-based funding, not vice versa. That's the challenge that we're all in at the moment. I think that's all I was going to cover off for the moment. I might hand to back to James now, who's going to, I think, go through the last couple of slides.
Thanks, Frank. And I just also acknowledge the work that MHA has done with us has been really good, and it's been great to have your help and support and challenging some of the assumptions we've made along the way when it's been appropriate. So thanks a lot. So I guess we're now open to questions. We've got a couple here, so I might just work backwards through them. The first one, Frank's for you, from Russ W. When do you expect to see directions from government on new models of commissioning, and what direction do you expect them to take?
Sure, thanks, Russ. You'll see, if you follow our work closely, that we've been for some time now pressing on government the need to have some of its responses to the National Mental Health Commission's review well in place by the end of this year. And at the launch of Are You OK Day just yesterday, I was with Mr. Susan Lee, who said words to the effect that she was going to have some very strong statements to make in the Parliament around mental health before the end of the year. And I think what she was really saying is they're getting very close to actually publishing their response. I think that's going to see a couple of things. I talked about commissioning earlier. It seems pretty clear that the government are committed to primary health networks and are committed to localising and regionalising the commissioning and purchasing of services, and so I think we'll see that drive going forward. We've also, as you've seen in other areas, like the NDIS, seen a bit of a shift towards individualised funding packages, and I think that that continues in many areas too. But a little bit contrary to that, we also have I think a recognition, or an increasing recognition, that individualised funding packages are appropriate for all forms of care, and that in parallel we're going to have a range of block-funded services and programs that allow us to ensure that services are available to a broad range of the population and can be planned. So I think it's likely that we're going to get a response from government over coming months. I don't think that'll be that will have an immediate impact, because I don't think primary health networks, for instance, are yet ready to undertake some of that work. But I think what we are likely to see is incremental steps moving us towards a commissioning model which is much more about purchasing very specific services and even purchasing very specific outcomes rather than I think the majority of what we've seen to date, which is block-funded programs for a broad range of population. So I think the work that we're doing in this classification work is going to assist us to mount our arguments in those new fora.
Great, thanks, Frank. Now we've got two questions from Annette B. And just before we go to those, just encourage people, if you've got questions, just type them into the box and we'll do our best to answer them. So Annette's asked two questions. How much data do we have on allied health interventions, and what evidence do we have about nutrition-related problems? So to start with, for admitted patients, we have a very good record of nutrition-related issues, so that's good, and we'll be able to use that when we get to pricing. And on the allied health interventions, Jennifer, I think we collected that through the study.
We did. So the costing study involved collecting a lot of information about the different sorts of interventions, which included a range of allied health interventions. And so clinicians, allied health workers were asked to essentially keep a log of all of the interventions that they provided to an individual, and we saw a huge amount in there in that respect. So we've been able to factor the costs associated with that into the classification work. We're also looking in relation to physical health and nutrition related problems. We're also looking at clinical complexity in the classification itself. So both the primary and a range of different secondary diagnoses and how these can impact on the cost of providing care to an individual.
I might jump, James, to say that I think you've identified one of the issues in it, which is to say that this classification system has boundaries and sort of has to have boundaries. It started at the hospital, and happily, I think IHPA have defined the sort of boundary of the work really quite broadly to take into account many of the activities that are occurring in the community. But at some point, IHPA's mandate runs out, and we run into then other, not just health, other social service interventions and so on. And one of the challenges that we've been keen to sort of identify and keep returning to is that boundary, the classification boundary, doesn't necessarily occur at the boundary of the organisation. It can occur in the middle of an organisation's work. So for organisations that are delivering allied health services or sports or NDIS supports and so forth, then some of their work is likely to be captured by IHPA, some of it is not. And we've been eager to try and sort of entertain the discussions that make sure that the work that IHPA are doing around classification is highly compatible with the sort of work that might be done in other forums as well, because ultimately a single organisation is not going to want to have dual systems for classifying and collecting information, and that is just one of the challenges that we face in this area of both recognising that those boundaries are appropriate at some level, but also doing the work that we can to ensure that that doesn't have an impact on the organisations that might work across those boundaries.
Yeah, thanks, Frank. That's a really good point, and there is a challenge for us of where the classification stops, but we have been saying for some time now that we will continue to build the classification as broadly as we can over coming years. So we'll keep working with you on that one. So we just had a question come up from Erica C. A quick question: how and whether relapse and long-term change are built into the cost models. For example, cheaper interventions may provide symptomatic relief, where the slightly more intensive, costly interventions may greatly reduce the likelihood of later service use. And I think the simple answer for that is at the moment that probably isn't addressed in the classification system. So there is still a role, I guess, for states and territories as health system managers, for health service managers, and for professional bodies and peak bodies to continue to advocate for the best models of care. That ABF isn't the silver bullet that will fix every problem in the system. But having said that, I think one of our clear goals is that over time, once we've got the building blocks in place, is to move to an outcomes-based model rather than outputs. And we are already doing work on this in the acute physical space with the Australian Commission on Safety and Quality in Healthcare, and I certainly expect that work will continue and broaden into mental health in the coming years. But I guess the necessary step to get there is to have a good output-based classification first. We can't do outcomes until we know about outputs. So that's, I guess, watch this space over the next few years.
I might just also add that I should probably make it clear that the classification doesn't look at doesn't classify per intervention. It's not a cost or some funding based on each individual intervention. When we look at the phase across, it's really the phase of a consumer's care. So within that, there may be a whole range of different things that happen to that individual, but what we're interested in is not each time something happens, but that period of time and the goal of care over that time. So that provides some flexibility in the future should services jurisdictions want to provide advice, that we're not limited to having an argument about just simply one type of intervention. So there's great scope for work in the future. But as James mentioned, as we've been able to move to looking at outcomes in some acute physical healthcare spaces, it's because we've got years of data that we're able to pore over in terms of those outputs to build an understanding of how you can influence outcomes. And we're early on in that piece in terms of mental health care, but we've got to start somewhere to build that data in the first place.
Cuts both ways. As I said earlier, the activity-based funding at its core is built around a system that replaces hips with prosthetics. You know, that sort of very simple notion. And I think as we bring community mental health into that fold, I think that challenges that old system and that old way of thinking, to think more broadly. But having said that, I think it's also true to say that there's a challenge for community mental health and for allied and other providers to be more clear about describing the sorts of services that we are providing, because it's not. It's very difficult to see a future for programs that are just saying, look, we're doing good work and leave us to it and give us the funding for it. You know, I think increasingly we're going to have to say, well, what are we doing? How do you describe it? How is a brief intervention different from an intensive intervention? Who is it delivered by? And what sort of outcome can we expect as a result of that? So I think there's a welcome discipline that I think community mental health can embrace here, to say, okay, well, how do we actually describe the things? And we're pretty confident that a lot of those things that we do are actually more effective than some of the things that might happen at the intent end. But in order to demonstrate that, then we have to describe, to count, and to measure the outcomes. And so I think it's an interesting two-way check we're facing.
Thanks, Frank. So I'll just see if there's any more questions, if people want to fire them at us. We've got about another 5 minutes. We've got some pre-submitted questions. So Liz Hudson asked us how community-managed NGOs were represented in the costing study, and also how consumer views are represented in future consultations. So I'll answer that question back to front. We've been very careful to get consumer and carer representation through this process. So we've got both a carer and a consumer on our mental health working group, who have been very helpful in making sure that we have kept those issues front of mind. And I can assure everyone that they've been very effective at that, and a number of times have probably pulled us up when we may have forgotten. So that's been good, and we also have had the public consultation process. We've had one already, and as Jennifer mentioned, there's another one coming in the next, probably the next month or so. So we'll obviously let you know when that's out, and let MHA hopefully help publicise that. So we'll be very keen to get feedback from both the broader mental health community, but specifically carers and consumers through that process. The community-managed NGO sector has been challenging for us to get involved in the costing study. The way that IHPA is structured, we work through the states and territories, through their health departments, and are reliant on the nominations they give us. And they were mainly hospital-based services. But I think the challenge for the next piece of work is to understand how we can involve NGOs more, and help understand what the data availability is in the NGO sector, and that will help us start to build the classification out broader. And we've got a very clear goal that we want this to be much broader than just hospital services, that we've already extended into the community for non-admitted services, but want to keep going further so that somewhere down the track there is a classification system that is seamless and moves across boundaries, and that will involve clearly a lot of NGO input. So that's work to come, and watch this space, and we're certainly
obviously something that's
over the next 12 or 18 months.
We've talked about that before. I just I guess reflect that the sector, I'm sure, stands ready to work with IHPA on that engagement process, because it is a challenging effort, and we'll look forward to assisting with that work.
Excellent. And we've got a question from Rosie F about details of the pilots and where they're being conducted. So Jennifer, do you want to give us a quick rundown?
Yes, so we are just in the preparation stages of the pilot, and it will start in a couple of weeks' time. It's running through services in Victoria, South Australia, New South Wales, Queensland, and Tasmania. They're public mental health services, so I think we've got Whyalla on board, Westmoreton, St George Hospital in Sydney, and then Tasmanian North Mental Health Service. I think I've got them all there. So that's a mixture of services that participated in our costing study, so that we can understand some of the training requirements and how we can improve those over time, so people can give us some feedback, and some new services as well. They're across the admitted and community settings, and they're intended to build on the costing study. So in terms of NGO involvement, that's a discussion for a little bit later on, as James and Frank mentioned. But we'll have information on our website available about that, and we can certainly circulate it to MHA as well.
Great. Okay, so I think we're out of time, so we'll wrap it up there. A recording of this webinar will be available on the IHPA website, and I think on the MHA website in the near future. So if you want to share that with your colleagues who weren't able to make it today, that would be great. You can see on the slide now we've got some links to various web pages that have more information, and importantly email addresses. So if you have any specific questions we haven't covered, please feel free to get in touch with either Jennifer or Vanessa at IHPA, and we will endeavour to answer those for you. And we've also got a lot of information on our website, so it's a good place to start. But certainly happy to
Louise
hear from you.
and Louise O'Donnell at our place will be very happy to help out members and others with information. As I said, there's a lot of resources now, a lot of interaction through the website. So if you've not been involved in that previously, then by all means make contact, and we can ensure that you're part of those groups and that involvement.
Okay. Well, thanks very much for joining us. Okay. Well, thanks very much for joining us.
James.
Thanks, Frank.
Thank you.
On Are You OK Day. So
thanks, everyone.
I hope everybody has a good day. Thanks.
Thank you.